Hello, good afternoon to all our participants joining from Europe. Good evening to our participants from the Asian continent. And if you're following us from America, a very good morning. I'm Maria Taborda-Küpper, and it's a pleasure for me to join you this afternoon and to introduce you to a brief update on the therapeutic possibilities of CytoSorb in the field of liver dysfunction. Then with that, let's start our session that we will briefly summarize in three major areas: an introduction to the hemoadsorption therapy, the application possibilities in the field of liver dysfunction, and a quick but comprehensive overview on the available publications and scientific data generated so far. With that, the first thing that I would like to introduce, both for the ones familiar with the therapy and for our potential new followers, would be the concept of hemoadsorption, which is based in the principle of extracorporeal blood purification by means of contact of whole blood with polymer-based beads that allow to remove specifically hydrophobic substances from the blood of the patients within a size range ranging between 10 and 60 kilodaltons. It is important to notice that this method is independent from filtration, dialysis, ligand selective, or washout processes. Therefore, this enables us to offer a new and different possibility of purifying substances from the blood of our patients. And also important to highlight, this process occurs with the CytoSorb device due to the fact that we are working on concentration-dependent basis. There is no blockade of any substance that is circulating in the blood, but rather a removal of high circulating values. And once this concentration reduces, it does not remove completely any substance. It is, therefore, an approach that enables us to provide a safe approach for our patients. Due to the size selectivity of the absorption, you have the possibility to preserve larger molecules that you wish to keep in blood of their patients, namely albumin, immunoglobulins, coagulation factors, and smaller substances that one might be also worried by its inappropriate removal, example given micronutrients or electrolytes that are too small to be captured within the pores of these beads. The device itself, the beads are very, very biocompatible. This is also very important to highlight because no adverse events related to incompatibility can be seen with the CytoSorb therapy. And as mentioned before, very central to our approach, the concentration-dependent removal. There will be no complete elimination of any substance. And when we are trying to remove substances from the blood, and we are afraid of the potential impact of reduction versus elimination or blockade, this is very important. No substance is removed completely. With this and within this absorption spectrum from 10 to 16 kilodaltons, there is a myriad of substances that are of interest for us. Currently, the CytoSorb devices are approved formally for the removal of cytokines, ranging from the most known ones, interleukin-1 beta, interleukin-6, 8, 10, tumoral necrosis factor alpha, among others, but also for the removal of myoglobin or the removal of bilirubin, which is what makes this session interesting, but also the removal of medications such as Ticagrelor or Rivaroxaban, which are known as antithrombotic medication, and this applies in the context currently of cardiac surgery. More information regarding which substances can be removed and how does this can transfer into clinical results for our patients can be found in the document Considerations for Use that is available on our website. And with this, I would like to bring you to the second part of our session, that would be the concept of liver dysfunction and the hemoadsorption role in it. The first thing, and as an intensivist, I must admit that probably our first more common bias is how do we define liver dysfunction in the critical care scenario? We are accustomed to talk about entities where the primary liver disease is the problem. That can be acute liver failure, or maybe a patient with a chronic liver failure that decompensates acutely. But beyond these conditions where the liver of the patient is primarily affected, we do have a myriad of other conditions in which the need for extracorporeal support or for a way to remove substances and to improve the condition of our patients might be needed. Example given, the post-hepatectomy liver failure. And in this case, and we might be familiar with this in our intensive care units, both from the oncological or the traumatic admissions, we have a liver that is technically normal, but that has suffered a reduction in its functional volume. This has occurred suddenly, and these patients might suffer from an acute onset of a liver dysfunction that is not necessarily a definitive one, but during this phase, while the remnant volume of liver that has been kept adjusts to the new physiological condition, the patient might suffer from very, very serious consequences. Also, a very common scenario that we see a lot on the critical care settings include the concept of the drug-induced liver injury. And this is not uncommon. The medications and the parenteral nutrition that we administer to our patients in the critical care scenario might generate damage to a liver that was previously healthy. The same occurs with also not yet so well defined, but unfortunately very common condition that is the sepsis-associated liver dysfunction. The patient is admitted and sepsis remains a paramour reason of admission for our patients in the intensive care unit. And though the liver is normal, the impact or the direct toxicity by the pathogens or the impact of the ischemia and the hypoxia can determine damage to the liver. And the liver is secondarily affected, not primarily, but also can present in the form of a dysfunction. And last but not least, and unfortunately also way more common in the last months, and probably is a trend that will continue in the future, patients being admitted with the concept of secondary sclerosing cholangitis after suffering from a critical care illness. Patient is a patient that is usually has a previous history of extracorporeal life support or a severe hypoxia and ischemia or very prolonged shock times that recovers from the acute phase and sometimes is even dismissed from the ICU and is readmitted later in the context of liver dysfunction, but the main cause, instead of being a primary hepatocyte damage, seems to be fibrosing damage of the cholangial vessels. That seems to be the result of this trauma induced by ischemia and necrosis. But independent of the cause, we have common aspects to all liver dysfunction scenarios that are well known by us. We tend to observe an increase in the liver enzymes, namely transaminases, but not exclusively, a rise on the liver toxins itself, and impairment not only of the coagulation profile of our patient, but also of other synthetic functions that are relevant for us to consider within the diagnostics. Independently of the cause, the initial event that occurs and produces damage to the liver, what we tend to observe is first a phase where a rise in the liver toxins occur, and not only in the toxins, in the enzymes as well. But usually, this patient rarely is admitted so quickly in our intensive care units. Most commonly, this patient is admitted once secondary organ dysfunction occurs. That can be as simple as brain failure. The patient is admitted with a severe hepatic encephalopathy, or in the context of a subplegic shock, that might be septic in the context of a patient with acute and chronic liver failure with a spontaneous bacterial peritonitis, or can be kidney injury. And in this context, what is relevant for us to know is that liver dysfunction can and will, if untreated, if not compensated yet, will lead to multiple organ failure. That occurs in the spectrum of not only the auto-intoxication, determined by the rise on substances like bilirubin, bile acids, or even ammonia, but also in the side of the immune dysfunction. Let's not forget the very important role that liver plays in the immune response of the normal physiological response of our patients. And once the liver function is affected, we can count that profile of inflammation of our patient will be altered, and this will determine outcome. The detoxification impairment also leads to organ damage, and I might allow myself here to admit a common bias that many clinicians, including myself, still had for a long time. It is that we tend to associate bilirubin as an hydrophobic substance and a degradation product of bilirubin as only responsible for jaundice. And therefore, and as certain authors have very accurately stated, only as a problem of color. But with the exception of newborns, where we tend to be afraid of the impact that the accumulation of bilirubin might have in the deposition and the creation of kernicterus, we rarely assume the severity of bilirubin and the impact that might have in later outcomes of our patients. But fortunately for us, this has been also demonstrated. It has been, not from this year or last years, but in some years already, associated that the higher the bilirubin values circulating of our patients, we can not only count with a prediction for poor response to vasopressor therapies in patients presenting hepatorenal syndrome in the context of acute kidney injury, but also that bilirubin seems to be an independent predictor for mortality, not only in septic patients, but also in patients undergoing ECMO support. And with the bile acid, we have a similar situation. Clinically, the biggest hallmark or the biggest problem that we have addressed or correlated to the bile acids is a pruritus. And this is a patient that is well known in hepatology wards, but also the impact that the bile cast nephropathy and the accumulation of complexes of bile acids and bilirubin in chronically ill liver patients might have explains the progression to kidney injury and to kidney failure. And I think that in this case, an image is worth 1,000 words. And as you see in this very, very dramatic picture of an autopsy of a patient, it's very hard to expect the recovery of the kidney function once this damage has occurred. As well, the dysregulated immune response and the hyperinflammation ensuing, it's not only a problem of a specific type of patients. Already the group of Dr. Wu have described with plenty of detail how the direct effect on the tissular and cellular damage of the hepatocytes that ensue in acute liver failure can correlate to activation of both intrinsic and extrinsic pathways for hepatocyte death, in which the common thread is not only the oxidative stress, but also the rise in pro-inflammatory cytokines and the rise in the expression of signalizing receptors for the cytokines. This means the result of the direct injury to the hepatocyte will express in the form of an immune-mediated liver injury. And in the case of acute and chronic liver injury, already the group of first and collaborators have also very, very precisely depicted how the balance between the pro-inflammatory and anti-inflammatory response of the patients with acute and chronic liver failure determines the progression, and how when the patient reaches the ACLF status and the progression to a critical condition, the spillover activates an inflammatory excessive immune response. And this activates secondarily immune cells that are circulating. So it is for us of utmost importance to acknowledge the role that hyperinflammation plays in the deterioration of our critically ill liver patients, regardless of whether it's an acute liver disease or a chronic liver disease that is exacerbated. Hyperinflammation, as also described by the group of Dr. First, also seems to be a determining factor in the progression between compensated status of cirrhosis and, as you see here, the surrogates of systemic inflammation rise from the compensated cirrhosis all the way up to the status of ACLF. Also, hyperinflammation in the context of sepsis-associated liver disease is worrying, not only because we are dealing with hypoxia and with cell death associated to hypoxia and to circulatory issues, but also with activation of inflammatory pathways. And this is what determines, or this imbalance between hypoxia, inflammation, and the normal regenerative response of the liver is what determines the progression, not only to fulminant liver failure or progression to fibrosis and cirrhosis, but also to repair. This means inflammation needs to be addressed cannot be completely suppressed because we still need inflammatory response or anti-inflammatory response, enabling the patient to heal. But it's also important that we consider inflammation as part of the critical pathways to address. And last but not least, and this is a very dramatic scenario every time that we admit a patient in the intensive care unit in the context of hepatic encephalopathy, it's an urgent and complex situation where not only the problem is associated to ammonia, but also to inflammation. And this is very interesting to read, and I can address only this from a very honest approach. We tend to learn that our first interventions, and this is what is described commonly in guidelines up to now, to address the production of ammonia by the gut bacteria. And our interventions attempt as fast as we can to reduce the ammonia release and the ammonia production by the gut bacteria. We try to reduce brain swelling as fast as we can, but we have to consider, as described very accurately by the group of Dr. Montagnese and collaborators, that the problem is not only the circulating ammonia that crosses the blood-brain barrier, but also the presence of other toxins like indoles or mercaptans, but also the inflammation role that pro-inflammatory interleukins determine directly in the swelling of the neuron and not only in the microglia. And a more recent review by the group of Dr. Heusinger, published last year, already establishes, and I like very much this schematic depiction on how inflammatory cytokines and ammonia are hallmarks in the swelling response and the generation of free radicals that damage the astrocyte and that determines the dysfunction, not only of the astrocytes, but also of the neurons themselves, and how this leads to symptoms. In conclusion, we are dealing with a problem that is more than just ammonia. Now, our common question is, we have a problem, the liver is failing. Can the functions of the liver be replaced? To our best knowledge, this is the most easy answer. If fulminant failure is diagnosed, we know what is the way, liver transplantation. But between the moment where we determine that the patient meets the criteria for an urgent liver transplantation and the moment where the liver transplantation occurs, either on the side of the patient is in condition to receive the graft or on the side of the availability of organs, time is running. And not only time, the condition of the patient is worsening. Therefore, our question would be, what can we do in the meantime? And this has brought since years the question, since decades, of whether extracorporeal liver support might be a reasonable approach. Dr. Lee and collaborators already described a very interesting review on what do we expect or what we would expect of a liver support device. And as very profoundly described by them, we expect of them to bridge between recovery, either complete recovery if the patient is suffering from an acute liver dysfunction where no complete structural damage is occurring, or bridge to recovery to baseline if our patient has a chronic condition, but we need to stabilize him because we know that complete recovery might not be the case, or to effectively keep our patient in the best possible condition until transplantation occurs. But also, we expect of a liver support device to help us to improve the condition of the patient, not only by means of pure detoxification, reducing the amount of circulating toxins, but also by improvement of other organ functions, and ideally also improving the hepatic encephalopathy grading of our patient, because once our patient is in a grade 3 or a grade 4 in coma, in the worst case scenario, we don't know that the outcome probability is not good. And whatever we can do to try to improve this is already worthy. And recent guidelines in the management of hepatic encephalopathy in the ICU recognize already the role that extracorporeal liver support devices might play to improve hepatic encephalopathy and therefore provide us a bit of guidance in how to address this. But no, last but not least, as we have seen, toxins is only one side of the problem, the inflammation. We also expect of the device that provides liver support to help reduce the inflammation that is worsening our patient condition, but at the same time, preserving the necessary immune response. We need to find a balance between too much and too little. We want our patient to not be hyperinflamed anymore, but we do not wish for our patient to be immune paralyzed. And on all of these contexts, already, the therapy with hemoadsorption has proved that can help with these aspects of the requirements for a liver support device. Common caveats that have been seen in the past with other liver support devices strategies tend to include bigger problems that are common in the ICU. What happens when the removal is unselective and there are complications due to the removal? With the exception of therapeutic plasma exchange and high volumes, majority of the systems were so far unable to tackle the immune dysregulation. And not less important, procedure related. If the procedure is not safe, if adverse effects occur in our patients, of course, we will be more worried about starting to treat with liver support technologies. Also, complexity, length of treatment, needs not only for anticoagulation, but let's say biological products like albumin or plasma are common problems that we have to take into consideration when considering to administer extracorporeal liver support. The same with the lack of sound evidence. And a common question is there an impact on the mortality? Is there an impact of the grading? Is there an impact on the outcome? And this is totally understandable. We do need our best to apply our interventions with the best possible level of scientific quality. And last but not least, and unfortunately also very important in the healthcare systems worldwide, the cost. If the device is costly and its disposables are costly, this of course makes much harder for us to take the decision whether to start the intervention or not. At the end, we have to be run a very careful assessment on the cost of benefits of applying these interventions. With this, I would like to introduce why the hemoadsorption with CytoSorb might be a good approach to tackle liver dysfunction in your critically ill patients. And basically, what we can propose is to combine the possibility of binding and removing excessive circulating levels of protein-bound hydrophobic substances in the whole blood, namely bilirubin as per our approved use, but as you will see later, other liver toxins are also demonstrated to be removed by the absorption therapy, but also being able to tackle the hyperinflammation. Excessive level of inflammatory mediators can also be successfully regulated with the absorption therapy in these patients. And on top of this, you can apply this in whole blood independent from albumin dialysis techniques or from plasma therapies. But, and this is a very valuable tool, combinable at the same time. As we saw before, because the adsorption allows us to be independent from filtration or from dialytic techniques, you can combine this. It can be integrated into the renal replacement therapy of your choice, but also can be combined within the extracorporeal support therapy of your choice. For example, given patients receiving extracorporeal mechanical circulation can benefit also from the hemoadsorption if they are presenting liver dysfunction at the same time. And last but not least, enables you the possibility to apply this independent from the need of other therapies. If your patient meets criteria for liver dysfunction, but this patient has not yet presented criteria for starting renal replacement therapy, it can be applied autonomously in an hemoperfusion mode. And again, pictures say more than words sometimes. This picture is, of course, a very dramatic before and after, especially the after of the absorption therapy. But the message that I want you to bring home is bilirubin absorption specifically will be seen. This is not a correlation. There is no correlation between how much color does the device or the device obtains after finishing the therapy, but definitely is visible the impact already in the column, and it will be even more visible on the labs and the clinical condition of the patient. Think of it as a tool for extracorporeal support that, unlike albumin or plasma-based techniques that are already very well studied and that have the pros and cons, here we're talking about flexibility of application. Can be integrated into any renal replacement therapy circuit, can be integrated without the need for an extracorporeal circuit, or can be integrated in a passive bypass in the extracorporeal circulation in an easy and flexible manner. This is for me the critical message here. And by this, you will be able to target critical aspects of liver dysfunction. You can help reduce cellular damage. You can help improve the hemodynamic instability of your patient. If your patient is especially shocked, is a patient where the inflammatory profile is not the best one, this is a patient that most likely will respond best to the intervention. It can help to reduce immune dysfunction because does not only reduce circulating cytokines, but can also reduce pumps and dams that are worsening the inflammatory response of our patient, and the reduction of neurotoxins circulating and the impact in the improvement of hepatic encephalopathy might be your best tool to improve the outcome of your patient. At the end, it's a tool towards bridging to recovery if it's applied on time, or bridge to transplant if there is no other possibility of recovery in the tissue. The hemoadsorption does not change the fact that the liver had a problem, but sometimes the liver only needs time to recover. And this is exactly why the concept of bridging is so important in this type of patients. In acute and chronic liver failure, our proposal is simply to try to reduce this downward spiral of systemic high inflammation that leads to organ failure, and how this organ failure leads to that by tackling the most simple aspects, removing inflammatory mediators, reducing the circulating concentration of liver toxins. And with that, we have available since some months a few tools that might be of positive impact for you to assist with the therapy selection. And one of these, the first one, is this decision support card, where basically we list some criteria that might be of use and consideration for you to decide how to apply the intervention. Amongst them, we recommend to consider the absorption if your patient has high bilirubin values, of course, but can also be applied if the criteria is hepatic encephalopathy of a high grading, or patients with high circulating values of bile acids that are unresponsive to other therapeutic interventions, such as intractable pruritus. Also, to consider that if the patient suffers from concomitant shock that is not responding to standard of care, might be also of beneficial use. And this can be applied regardless of we are talking about acute liver failure or acute and chronic liver failure, or post-surgical or post-transplant liver failure. And with this, the second side of this decision support card addresses how to continue or how to stop. And in general, our recommendation would address three main roads that can happen with any therapy. We see sufficient improvement and stabilization with one device, and one device has been sufficient. Sufficient stabilization or clinical improvement has occurred, but is yet not sufficient. And this is the most common scenario. You need to reevaluate the condition of your patient, and with that, make the decision of replacing the absorber every 8, every 12, or every 24 hours based on response. Or the most unlikely scenario, but can also happen, that the therapy is applied in a patient that is not responsive, probably because organ failure has occurred and is irreversible, in which to consider the futility of the therapy might also be a scenario. If after 2 absorbers, no clinical or biochemical changes of importance have occurred, then of course it's reasonable, especially if the clinical improvement is nowhere to be seen, to consider if the therapy has not been successful, like with all interventions. Also released a few months ago, we have available also on our website a very nice flow chart developed by our medical strategy colleagues, where the concept of how to integrate this knowledge into a clinical conduct might be of use for you. If you have a patient with acute ongoing liver dysfunction that meets potential criteria to start the therapy, and please note here that we like to add also signs of a hyperinflammatory response that might include parameters that you might have in your practice or not. For sure, almost everyone will be able to measure C-reactive protein, but you might also be able to measure procalcitonin. And if you have interleukin-6 and the interleukin-6 values are above 500, also might be very helpful to enable you to take the decision, then you can decide to start the therapy. As described in our previous slide, the important hallmark here, reevaluate, especially with bilirubin, reevaluate your patient every 8 hours. And this allows you to measure how your bilirubin values are looking like, how the clinical condition of the hepatic encephalopathy is looking like, how the ammonia levels are looking like. And based on that, if your decrease curve is insufficient, you might consider an earlier replacement of the absorber. But there are plenty of patients and literature supporting that in some patients that are still responding, you could still go up to 24 hours per each device. And until when? until signs of clinical stabilization are to be seen. Here it's very important to note that as doctors, as clinicians, for us, clinical improvement will always be the main hallmark of success of the therapy. So if your patient's hemodynamic instability is reverted, if your hepatic encephalopathy is improving, and this is consistently accompanied by a reduction of your hyperinflammatory response and reduction of your bilirubin values, these are the signs that indicate you that the therapy is successful. I don't think that it's sufficient to say you will achieve a reduction of bilirubin values, but rather therapy should continue until the clinical condition of the patient is better. And to the question, how long can the therapy last? As long as patient needed. In our literature database, I think that the longest documented case of liver support administered with CytoSorb was 55 days in a burns patient with liver failure. But can be as short as 1-2 days, can be a simple short bridge to transplant, or can be a bridge to, or can be a treatment for hyperbilirubinemia that ensued after ECMO support or after surgery or after medication. Individualize the length of the therapy based on the condition of the patient, based on the control of the cause and the type of cause. It does not look the same in a patient with acute liver failure that might have a chance for recovery of the liver tissue, that a patient that we do know that the solution is at the end a transplant. But this is, for me, very important to highlight here, that the maximum duration recommended by for any adsorber from our instructions of use is 24 hours. So we recommend to adjust the duration of the therapy based on the patient response, but at least every 24 hours, you should be replacing the adsorber. And with this, I'd like to go to the third section of our session today. That would be a review on the clinical data. And the first, and I'm rather focusing here on data obtained of case series and prospective data instead of simply case reports. I think that the first one to mention was published end of 2021, already describing the impact that hemoadsorption had in the subset of patients with liver indication within the CytoSorb registry conducted by the Jena University, but not exclusively by them. It was a multicentric registry study. And with that, the analysis enabled us to observe the delta on the bilirubin reduction obtained in patients that had hyperbilirubinemia. Please notice that this only proved the possibility of removing bilirubin, but did not provide at this exact very moment concrete statements regarding clinical outcomes. So the findings were that the significant bilirubin removal could be demonstrated clinically and not only in vitro, and that this would enable the design and the conduction of further studies that should better assess the role of hemoadsorption in liver dysfunction. We do know already from studies also performed in vitro as recent as 2021 that CytoSorb has a very good in vitro performance as a liver support device, even superior to what we consider by then the hallmark that was in this case the molecular absorption recirculation system, or by its acronym, the MARS. And this study conducted by Dr. Dominic and Dr. Stanley tested in vitro the depurative, the detoxification capacity, you see in black, the residual levels of bilirubin, of bile acids and ammonia by MARS system versus the residual levels of bilirubin, bile acids and ammonia obtained by CytoSorb in the gray columns. But this study not only tested the depurative capacity for common liver toxins, but also for inflammatory mediators. And concretely in this study were tested for interleukin-6 and tumoral necrosis factor alpha, where the capacity of removal by CytoSorb is considerably bigger. And with that, the conclusion allowed us to demonstrate that fast removal of cytokines, but also reduction of albumin-bound toxins could be demonstrated in this in vitro model, which already from the mechanistic aspect showed that CytoSorb was already a feasible therapy. But how does this translate to clinical results? One of our first retrospective series addressed from the group of Dr. Calabro in Italy, already addressed a subset of patients with multi-organic failure, some of them in livers, in extracorporeal support. Please notice, patients that did not receive ECMO support received hemoperfusion mode. These were not patients with kidney injury, but only with liver dysfunction or with multi-organic failure that did not receive concretely renal replacement therapy, assessed from this subset of patients, 28 patients out of these 40 that were admitted due to hyperbilirubinemia or to acute liver failure for CytoSorb use, not admission to the hospital, but for CytoSorb use. And of these, it is important to highlight that between this subset of 28 patients, they managed to demonstrate not only significant reduction on the total bilirubin circulating, but also, and completely attributable to the effect in the organ function recovery and not by direct removal, improvement on circulating lactate values as high as 12, which was the peak during treatment in mean value, to 2.9, but also improvement on the creatine kinase and lactic dehydrogenase values, which are substances, the three of them, way bigger than what can be absorbed by the device, which impacts or is a surrogate for the impact that the recovery of the organ function expression can be like. Also, is accompanied by a reduction in the vasopressor needs and a reduction of the expected mortality in these patient groups. Another case series from the group of Dr. Tomescu in Romania was able to gather the data from 28 patients with different infectious and toxic causes for acute liver failure. And basically, they were able to demonstrate in these patients not only consistent and significant bilirubin reduction, but also reduction of surrogates for inflammation, like C-reactive protein, which again, it is due to size, also a substance that cannot be removed by absorption, but also managed to demonstrate a reduction on the ammonia blood levels, and I need to emphasize here on blood levels, from as high as 100 to as little as 64 in mean value after the therapy. And also a positive impact in the SOFA scoring in the sub-SOFA scoring for liver. Still, these patients with acute liver failure are patients that tend to have a very high mortality rate, for which was already a very positive effect, to observe that the survival at the 28 days was 64.3, namely 18 out of these 28 patients, showing not only that there was an improvement on liver functional tests and decrease of C-reactive protein, but also a positive impact or a suspected positive impact in survival. Another case series for the group of Dr. Scharf in Munich, also published in 2021, and able to compare how the acute liver dysfunction patients could be treated with two different extracorporeal support devices. In the case of the group of Dr. Scharf, their device of choice was the ATVOS, and basically they selected patients with acute liver dysfunction and very high bilirubin levels, above 10 milligrams per deciliter, and these patients were assessed to be treated either with combination of absorption with CytoSorb integrated in the CRRT circuit versus the ATVOS system, which is a multi-organ support device. They were also able to demonstrate that all of these patients had, including the CytoSorb patients, very high increase in total bilirubin before the treatment, which correlated with very high decreases after. And you can see here the relative reductions of bilirubin, both for CytoSorb and for ATVOS, pre and post-treatment, the -1 for treatment, after treatment. But also that in the group treated with CytoSorb, decreases in the transaminase profile were to be observed and attributed probably to the organ function improvement. And I think that this is very valuable to add here, that these are not expected results of the absorption directly. And with this, the ease of use, and this was one of the most interesting conclusions, provides an advantage. It is quite easy to integrate this into any extracorporeal circuit. More recent, and belonging to the concept of update here, a new publication, as short as some weeks ago, also from the group of Dr. Tomescu and Dr. Popescu in Romania, also contrasted and matched two sets of patients treated with CRRT plus absorption with CytoSorb versus patients treated with the MARS system. And this group of patients were patients with either acute or acute and chronic liver failure that had to meet certain criteria to enter. The first one were patients with acute kidney injury, but also with severe encephalopathy and with very high bilirubin values, above 30 milligrams per deciliter. And with that, they were also able to demonstrate that reduction of circulating bilirubin, ammonia, and lactate, and lactic dehydrogenase was to be found with the AMO absorption. But not only that, they were also able to demonstrate that synthetic functions of the liver and the international normalized ratio as a surrogate could be seen with the patients treated with CytoSorb, which is a very interesting finding because it supports the theory of improvement of organ function, as well as an improvement on the hepatic SOFA subscoring and even the MELD scoring for the acute and chronic liver patients. And also a clinical effect observed, also very valuable one, improvement of hepatic encephalopathy, which led them also to the conclusion that between these two systems, they could speak in favor of the absorption with CytoSorb for an increased detoxification capacity and the ease of use. Another very recent publication from the group of Dr. Hui in Hong Kong addressed the combination or the case of using absorption in pediatric patients. And this case series comprises 6 patients ranging between 8 months to 18 years treated with either absorption with CytoSorb integrated in the CRRT circuit or patients treated only with single-pass albumin dialysis. This group of patients had all possible causes of liver failure, and their bilirubin mean value prior to starting the therapy was 23.6 milligrams per deciliter. And their findings supported not only that a significant decrease of bilirubin was occurring, and this is plotted here per patient, but also that there was a very interesting correlation between the high levels and the higher the levels of bilirubin were and the dosing of the absorption, namely the dosing expressed as liters per kilo of purified blood. They also saw, especially in patients with very high circulating values of bilirubin, that in these cases, saturation might be seen already at 8 hours after starting the device, which of course for them was a prompt considered to replace their device earlier if needed. And also a very important finding in the patients treated with CytoSorb was that they could demonstrate in some of them admitted with coma, with hepatic encephalopathy grade 4, that the patient was able to recover from coma and to survive and to leave the hospital, which is a very interesting outcome as well. And they were also attempted to provide a calculation tool to determine the removal ratio per session, and they found an interesting percentage of removal bilirubin per ratio of 44.6. And with their conclusion, they were able to compare that in depuration capacity, in amount of purified blood, of purified or removed bilirubin, they found a similar pattern between the single-pass albumin dialysis and CytoSorb, but had to speak in favor of CytoSorb because it's easier to use to install and to run effectively a single-pass albumin dialysis in their patients. And also, and before closing, getting back to your questions, a very recent publication as well, also from the group of Dr. Liebsche, Dr. Scharf, and the CytoSolve study group, that is still recruiting patients in Munich. They have published recently a communication where they are addressing the context of ammonia removal. And I think that this is a very interesting question to bring to the discussion, especially with the absorption, and especially because nephrologists, hepatologists, and ICU specialists that focus on liver failure know the same issue. Ammonia is a small hydrophilic substance, therefore might be removed by other techniques, including renal replacement therapies. Basically, their finding was from the first 20 patients that they have recruited with total bilirubin above 10 milligrams per deciliter plus indication for CRRT, that they wanted to establish whether and when, or better said, in the circuit of the hemofilter and the CytoSorb, where is the ammonia removal occurring? For this reason, they have taken patients that had a mean ammonia serum concentration of 77 micromoles, and they have performed measurements from the arterial cannula and from the CRRT circuit, which would be the equivalent to a pre- and post-adsorber measurement. And their findings, to summarize, tend to address that the removal apparently is occurring in these patients by the dialyzer or by the hemofilter, but not directly by the CytoSorb. And of course, this is a very valid result based on the fact that the ammonia is a small hydrophilic substance. Nevertheless, this is what I would like to bring you to attention on this topic. The first one is there are in vitro studies still demonstrating ammonia elimination, as seen before by the publication of Dr. Dominic and Dr. Stange. And case series and case reports up to date, they have not addressed the direct ammonia removal pre and post adsorber, but rather, and this is very important, and for this reason I emphasized in this some minutes ago, lower ammonia serum values. It seems like the combination of CRRT plus CytoSorb is leading to clinically significant improvement in the ammonia circulating values, but also in the improvement of hepatic encephalopathy, which is at the end the clinical goal that we would like to address. And no less important, at least 2 studies, including still the CytoSorb, which is still recruiting patients, are still open and attempting to determine better the role of the hemoabsorption with CytoSorb or the impact of the CytoSorb therapy in the ammonia removal for these patients. So we can expect with that more news in the future. Other case reports and series you can find in our database addressing combinations for patients with all possible diseases. It might include combinations also with plasma exchange. So there is a very recent case report from Dr. Gunasekera and colleagues, also from the impact in septic-associated liver dysfunction or as bridge to transplant in smaller patients. They are all available in our database. And to summarize and take your questions, I would like to leave you with these 4 key take-home messages. The first one is, as we have seen, that liver dysfunction remains still a clinical and complex situation where, unfortunately, we do not have the final answers. Though liver support is there since decades, it's still not quite integrated into our guidance for management of acute or acute and chronic liver patients, neither for adults or for pediatric patients. Most recent review by the Society of Critical Care Medicine in the US still addresses the importance of combining CRRT in the patients that might benefit, patients with clear indication for kidney replacement therapy and or plasma exchange, being the one that has at the moment positive evidence for acute liver injury. The impairment of the toxin clearance and the dysregulation of the immune response are, as described during the session, with organ damage and poorer outcomes. In this concept, the absorption attempts to provide an easy, flexible, and powerful tool that should be able to help to target this liver dysfunction and to provide improvement not only of biochemical parameters, but clinical. If the patient can recover hemodynamic stability, if the patient can recover from the hepatic encephalopathy, these type of clinical parameters are of relevance in the selection of the therapy and in the decision-making process. And like with every possible intervention, selecting your patient properly, starting on time before irreversible organ damage occurs, and dosing, treating enough and treating in the course of time sufficiently are fundamental aspects for a successful therapy. And with that, I would like to close. Thank you for your attention, and let me take a look at the chat and see which questions are still there. I have a question here from Dr. Muhammad. It is possible to use in hemodialysis therapy and possible length of duration. A pleasure to respond this question for you, Dr. Muhammad. Yes, can be perfectly integrated in hemodialysis. If your patient meets criteria for kidney replacement therapy, let's say fluid overload or electrolytic impairment or any other reason for which a patient might need renal replacement therapy, the hemoabsorption can be integrated into the circuit. Depending on the manufacturer of your device, the position can be either pre-filter or post-filter, but definitely can be integrated and will not modify any parameters of your selection of therapy. Can be done with filtration, dialysis, or diafiltration techniques, intermittent, long therapies, or continuous therapies. So in this context, you do not need to hesitate on whether this can be integrated, but rather how to start it. And for that, we are most glad to provide guidance. And anticoagulation, the same that you would use for hemodialysis therapies. You need a form of anticoagulation, like with any extracorporeal circuit, that can be without a problem, anticoagulation with unfractionated heparin, or anticoagulation with citrate. What you have available, what is the best practice? In this topic, we will hold specifically for the topic of anticoagulation and the impact that anticoagulation might have in liver support therapies and in CytoSorb, a webinar, if my memory is correct, in September with Dr. Ivano Riva from Bergamo, Italy, which is an expert in the liver support therapy with hemoabsorption, and which will be oriented to the practical aspects of how to perform this therapy and how to run anticoagulation, for which we would like to invite you all. How should be the blood flow with the hemodialysis machine? The blood flow, the minimum blood flow that we recommend to apply the hemoabsorption in these patients is at least 100 milliliters, up to at least 700 milliliters. This is what our instructions of use say. I also have to say that especially in pediatric patients, not in the context of liver failure, but in other contexts of hemoabsorption, there are case reports describing lower blood flows as low as 60 milliliters per minute without clinical adverse events. But need to emphasize here that with blood flows, the same happens as when we are doing liver dialysis techniques. The lower your blood flow, the higher your need for an effective, successful anticoagulation. So here, very, very critical. You can work with 100 without a problem. Please ensure that your anticoagulation is on time. And if by any chance the patient is not tolerating this, and the decision to go with an even lower blood flow ensues, then you have to first be very careful that the anticoagulation is at its best effective prior to starting the therapy and prior to do any modifications of the blood flow. But our recommendation remains minimum 100 milliliters per minute and as high as you wish. Any other question that you might feel free to share? I see that my colleague has replied already as plasma perfusion. Yeah, it's designated as a whole blood absorber. At the moment, we do not have sufficient clinical evidence to recommend the hemoabsorption with CytoSorb in plasma perfusion modes. We can say that there have been case reports, at least one, addressing the possibility of, if the patient meets criteria for therapeutic plasma therapies, namely absorption or exchange in CytoSorb, that this can be run in alternate days, as the group of Dr. Gunasekera have done, or even alternate. You could decide on this, but again, based on the patient. What here is critical is if your patient needs plasma absorption for the indication of removal of substances that are not susceptible by hemoabsorption, example given immunocomplexes, then it's understandable that in this case, you might need the two therapies, and probably the only scenario that has been clinically tested so far is the combination of this plus hemoabsorption in alternate times. But integrated into the plasma circuit, as my colleague has accurately written, unfortunately, we cannot recommend that at the moment. And with that, I would like then to close the session, to thank you very much for your attention, and looking forward to see you soon in our next academic session. Wish you a very nice evening, everyone.